So my name's Chris Baker. I'm an orthopedic surgeon in Tampa, Florida. I trained in Pittsburgh, Pennsylvania. I went on to do a sports medicine and shoulder fellowship in Greenville, South Carolina with Richard Hawkins. I now work in Tampa, Florida with the Florida Orthopedic Institute. Soft tissue repairs, probably the hardest part is mobilization and getting the tissue in the right spot. And then eventually it's outcomes. It's getting the soft tissues to heal. Rotator cuffs specifically, when you look at instability, labral repairs, we really don't have much issue with that. They heal and do well. But rotator cuffs, even in the best of case scenarios, sometimes will just fail. When a rotator cuff doesn't heal, there's usually two factors to it. One is that just the strain of it. Is the tendon under too much tension? Did we not repair it to the right place? The other is purely biological. So there's this kind of physical manner to it of getting it down and taking tension off of it. And then we have to get the biology to actually come in and heal it permanently. So re-tear rates are way higher than we want them to be. When we leave the operating room, we think surgery went well. That's why we did it that way. If we were to follow up with our patients, probably anywhere from 20 to 30% of them, even in good situations, probably fail. Luckily, we don't know it most of the time, but when we do, the patients definitely show symptoms of weakness and pain and decreasing function. The older you get, the more likely you are to tear. The more health problems you have, the more likely you are to tear. The poorer your bone quality, the more likely you are to tear. Nutritional status affects your ability to heal. And then there's the tear factors. How old is the tear? How long has it been there? Is the tear large or small? Is there muscle intact? Is there fat replacement? There's lots of factors that increase that risk. To me, there's two types of tears. There's traumatic and then there's atraumatic. Traumatic tears do extraordinarily well. So if someone falls off a ladder, they can't lift their arm, and we know that that day they tore their rotator cuff, we fix them, they do tremendously. People who come in with shoulder pain that kind of creeps up on them, they're the problem. They are the biologic problems. They're the ones that have tissue that doesn't have good quality, that doesn't have good healing potential, and they're the ones that re-tear. So augmentation to me revolves around, again, those factors for the patient as well as the tear. So larger, older tears, chronic tears, patients with comorbidities, they're more likely to get a graft in my hands. Right now we're working with a graft that's based out of a hyaluronic acid graft that is a solid hyaluronic acid, and it has a woven polyethylene within the graft itself. And we think that that might be the sweet spot in improving the biology of the repair. Partial thickness is probably like the easiest way to fix this is with an augment, because we're no longer having to take down normal tissue. Traditionally, what we did to fix partial tears was we would either complete their tear and actually create a full tear. Now we've injured good tissue. Now I don't have to do that. I can put a graft right over top of that. That allows my patient to heal faster, get back to their life faster. They don't have to be in a sling as long. And then the full tears, we'll definitely be using those as well, because those are the ones that typically re-tear. So with the Integrity, what we've really tried to do is really walk the line between the pros and cons of all the grafts out there. We try to have something that has some time zero strength so we can manipulate it and provide some strength to the graft. We've tried to find something that is biologically active that's going to help heal the repair, and then something that's easy to implement, because you really need all three of those to use them appropriately, consistently, and for everyone. When I found out that Annika had the ability to manipulate the gel form of hyaluronic acid into a solid, and that this was already being utilized for cartilage restoration, that kind of is where it was born. Orthopedic surgeon, shoulder thinking and technology driven from Annika, and combining those two kind of tool and need and making those work is how we ended up getting to the patch. So collagen has pros in some cases in that some are linearly aligned. Collagen is what most of our tissues are made of, but it also has some cons, as in that most of it is coming from a xenograft versus from a human source. Then there's going to be processing of that material that weakens the material. So there's lots of factors that change depending on how that material is made. The combination and integrity of hyaluronic acid, 80% versus polyethylene, 20%, there needs to be enough structural support to hold the graft to give it time zero strength. If we made it 100% hyaluronic acid, that might have a lot of biology, but it wouldn't have as much strength. So by weaving it with the polyethylene, we create this interlocked woven fashion that allows us to give some strength to it at time zero, as well as that biology. So that 80-20 mix seems to be right for us right now. The polyethylene that's within the Integrity implant itself is less than what I would typically use in a 4-anchor cuff repair anyway. So having that little bit of polyethylene in the mix has no real issue to me from a standpoint of rejection or longevity. We're basically going to get a layer of tendon-like tissue on top of the tendon, and it's going to be like a sandwich with the graft in between. So the benefit of both implants, so the PEEK staple has the staple that has a central cannula that's hollow. And your inserter device is the punch within the staple, right? So it's one step. There's no punch, dilate, then put the implant in. So having one step makes it easy. Well, the same thing applies for the PLGA tacks immediately. You impact it, I like to tap it in personally. I think I have better control doing that. I'll typically hold a little bit of counter pressure and kind of twist the inserter handle out so there's not too much friction. And then that's pretty much it. The beauty of our medial implanting of these versus other implants is we can get to really acute angles. So you don't have to be exactly perpendicular to your tissue. You can have a very high angle of insertion of that graft into your deeper tissue, and it's not gonna cut through the graft like a lot of them will in the market. So I think if you're gonna use an open application, bigger is definitely better because you're talking about bigger pathology. The rotator cuff is very small compared to the hip abductor tendons, the patellar tendon, the Achilles tendon. The rotator cuff is tiny. So if you were to take our little pledgelet, it probably wouldn't cover much real estate. Taking those larger grafts and wrapping it around the tendon and getting full footprint coverage will make us feel a lot better about it. So when it comes to the patients, I simply tell patients that if they have a rotator cuff that's at risk, I tell them that I'm likely to graft their surgery. For them, they don't see positives or negatives to that. But when they hear that I'm thinking about protecting them from a recurrent injury and having more surgery, they're automatically on board. They know that I've done hundreds of them. They know that I'm comfortable with it. So there's not any fear or anxiety toward it in any way, but it is something that they almost gain another level of trust because they know I'm looking out for them, trying to do more. My post-op protocols after Integrity use for rotator cuff repairs really depends on the rotator cuff. So if I'm doing an augmentation of a partial tear, they have a sling for a couple days, I remove it. I just limit overhead for the first 6 weeks. So they can work on rotation, internal, external. They can even strengthen internal and external. That will actually improve their ability to lift up in the beginning. The reason I don't like my partial tears to go overhead right away is the rotator cuff is weak and the deltoid will bring the shoulder up in the subacromial space. And I don't want the graft to grind on the subacromial space on that raw subacromial bone. For my larger tears, I treat them exactly like I would based on the tear pattern. If they have a large tear, they're in a sling for 6 weeks, pendulums and table slides. I don't start active range of motion supine till 6 weeks. If you do rotator cuff repair, you will see post-op stiffness, okay? When you add a new technology to something you're not used to using, and you have a patient with post-op stiffness, I think we get anxious and we like to blame and we want to get worried that maybe the graft is causing this. In my experience, I don't see any significant more amount of stiffness, but I do see stiffness. When I see stiffness, I educate the patient, hey, that's healing going on. The stiffness is a result of a reaction to the healing that's going on in the rotator cuff. We're going to rehab you through it and we'll get you through. I think the biggest hurdle for augmentation adoption is just comfort. I think a lot of doctors are comfortable with what they do. They think they're getting good outcomes. They stay away from getting new MRIs. And when that patient has a bad time, they just kind of tell them it'll be all right. I think as doctors get more comfortable that number one, this works, that they have something that's easy to treat that may remove those patients that fail, I think that will bring adoption in. So I think we need data to show them that it works. I think we need insurance companies to pay for it so that the doctor doesn't feel like they're swindling the system or costing the system money. And I think if we can prove that it works and we're saving money for the system in the form of not doing revisions, I think that everyone will jump on board with this because all of us know that rotator cuffs fail and we all want to fix it. I'd say if you haven't done an Integrity or any graft augmentation for that matter, I would take a patient who has a partial thickness tear, specifically like a bursal-sided partial thickness tear. Do your subacromial decompression, apply a graft to that patient, let them start moving with their arm down at their side early, and get an MRI in 6 months and see what that rotator cuff injury looks like before and after that 6-month period. You can do it sooner, but the changes on an early MRI make you uncomfortable. Wait for that 6-month period, get a new MRI, and then you're gonna see the results with your own eye on your own patient, and it'll change your thinking. Right now, the only data I have is my data, right? In order to gain levels of magnitude in research and validity to our studies, we have to enroll more doctors who are enrolling more patients with different problems in different ways. What we're working on right now is a prospective cohort study that's multi-centered with multiple doctors. That will give us data and numbers that we can then perform better analysis on. Right now, our enrollment's going great. We have a relatively tight enrollment in that it can only be like a medium or small size tear. Unfortunately, I do a ton of large tears. So even though I'm using the grafts, those patients aren't likely getting enrolled in the study. So we did an early study really to give doctors an understanding of what normal looks like after using Integrity. And what we found in our 10 patient cohort study, we took patients that had great range of motion, no pain, that were doing well at the 6 and 12 week mark. And we took those patients and we received an MRI on them at 3 months and at 3 months and 6 months. Those MRI studies, even as early as 6 months, showed great healing of the tendon with thickening of the graft itself over the tendon repair. And something that we didn't expect to see is we're starting to see a halo effect where we're getting growth of the implant even beyond the borders of where we inserted it. And that's a really encouraging thing because a lot of the tendon injuries we have are medial to our repair, the CHO type 2 tears, where we get this tear at the myotendinous junction. And if we can show that that is continuously improving and getting that halo effect, we'll definitely be improving patient outcomes.